getting our live stream set up here on Facebook. Thank you for joining me here. Let me get back to the presentation on this Friday afternoon. Well, it is 2 o'clock and all of you have taken the time out to join me. So I'm going to go ahead and get started. And if other people join on, that is great. Today will be a 1 hour live CEU for restorative techniques for deciduous anterior teeth. And I have to let you know that I have no financial disclosures or any financial interests in anything we are speaking today. I'm speaking to you as a colleague and as a pediatric dentist doing all of these techniques that we're going to talk about today. I do all of them. There's not just one that I gravitate towards. And that's part of what we talked about in our last webinar, the patient experience and meeting the patient with where they are. And if you missed that one's available on demand at pediatricdentalce.com. When we look at these deciduous anterior teeth, we really have a whole bucket list of options. We have options such as active surveillance. If they're a young kid and the mom's not interested in doing SDF, we may put them on a 3-month recall. We have arresting protocols such as SDF, and now Curodont is out there. Interim therapeutic restoration, we can strip the anterior teeth, do Hall crowns, we can restore them conventionally. Stainless steel crowns have kind of fallen out of favor. I will use those on canines sometimes for like a Hall crown if I have to. Resin veneered stainless steel crowns, they're kind of falling out of favor, but some insurances do only cover them and not the zirconia crown, so that may be an option. We'll talk about the advantages and disadvantages of those. Strip crowns, I don't do too many of these anymore. They tend to fracture a lot in my hands. Tend to do a lot of zirconia crowns and the minimally invasive dentistry. And another option, it's not restorative, but is always extraction for these kids. So keep that in mind. Sometimes you'll regret doing something if the kid's not that cooperative, and maybe extraction is probably the better route to go than try to be the hero and save the tooth that's broken down at the gum line. Active surveillance. This is a great program, but you really have to consider carries risk of the patient, their age, and the risk of sedation. So we know that generally speaking, the younger the kid is, the higher the risk is for sedation, because if there's a complication during the procedure, we can have loss of residual reserve of the oxygen that they have. So a lot of times if I have a really young kid and we know they're getting early childhood caries early, we'll put them on a 3-month recall so they can get the fluoride treatments. I can also reevaluate the lesions and see if that's going to be something we need to change our plan. And I base my evaluation on if these lesions are going to be pulpally involved in the next 3 months. And as you do this, you're going to get better and better at determining which cases you need to be more aggressive with. And also, some of these patients come in and they get new decay and the caries progress, and it's like, well, yeah, now it makes sense to utilize sedation to fix your child's teeth at this point with the amount of work that we have and the progression that we're seeing. Here's just one kid that I put on an active surveillance program, and he came in every 3 months and we applied the fluoride. You can see some things got a little bit bigger, but by all means, we're getting to the point where these teeth are exfoliating naturally without any invasive treatment. One way to get paid for this, I know everyone questions, I talked about this in the last webinar, how do you get paid for a 3-month recall? You can create an in-office plan and have that be a supplemental insurance for the patients. I am working on this and including SDF and protective restorations in there just so I can collect on that. And then also when it's time to restore the tooth, I can actually bill that to insurance and get paid for that and not have them say that I have to wait a year or 2 years because I applied silver fluoride product. Arresting protocols, we have all these silver fluoride products out there. Silver nitrate or house solution was one of the first, and followed by here now Advantage Arrest, the first SDF on the market. Revastar came out and I was really excited about that, and the pH of that's really high. So to be honest with you, that's not really indicated for a lot of young kids, because if you can't get proper isolation, it's going to burn the tissue. Now what I'm using is the Revastar Aqua. It's a water-based silver fluoride product. It does not have that burning that you do. And if they're not cooperative, I just use the first step. just similar like you would advantage arrest. And mainly for cases with indirect pulp therapy and permanent teeth is a great indication to minimize staining for those older children that can sit for 90 seconds for the application. There are some contraindications. If they have an allergy to heavy metal ions, if they have severe gingivitis and you put that Riva star in, it's going to make it really burning. It's not FDA approved in pregnant and lactating women, but it's really rare to have an adverse reaction to this. I've been placing this for quite some time now at my office, and we really haven't had any issues besides the kids complaining about the taste of it. So Revastar, this is approved for treatment of dentin hypersensitivity, and it has a second step of potassium iodide in it. And the contraindications for these listed on the UCSF consent form are pregnancy and breastfeeding as well. If you look at potassium iodide as a medication for treating like a radioactive event, these are the other contraindications that are listed. And the differences between the two products is it's kind of still out there to be seen. So I'll show you what I did at my office and the mistake I made, but for the KI to work, you have to apply it for 90 seconds. And if you're sitting knee to knee with a 1-year-old that's wiggling, how are you going to be able to apply that to 4 teeth for 90 seconds each and have it precipitate all the silver fluoride out? So here's what we're seeing in studies comparing SDF and silver fluoride and potassium iodide. We're seeing a great arrest rate at 30 months on all the lesions, about the same. And we're seeing about the same staining. And I don't know if that's because they're not applying it correctly or if it stains more over time. These were repeated visits at 12 and 24 months and then at 30 months. If we look at studies just looking at the use of silver diamine fluoride, we can get different arrest rates. These are from the past AAPD guidelines. You can see anywhere from 68 all the way up to 87 with these surfaces. So it's a little bit variable. And I think it's probably going to depend on, we'll talk a little bit here in a minute about the site that you put it on. And then also, if you can get a glass ionomer in there, if they can retain after that, I would highly recommend that you do a smart technique and place a glass ionomer so the food impaction stops and the lesion can have a little more protection while it's trying to arrest. If we look here further at SDF and silver fluoride and all the different things, if we're using a second step or not, you're going to see a lower arrest rate with the potassium iodide as the second step, but you're trading that off for having a more aesthetic outcome. And that may be something that you want to do at your office. You may just want to use the first step if you don't want to mess with the kid and have 90 seconds of application. But I think if we look at moving into the permanent dentition, some things may be a little more considerable with the second step. So keep that in mind. Lower odds of arrest with the potassium iodide, higher odds of avoiding the discoloration. That's our trade-off. And this study had higher rates of pulpally involved lesions, but if you look at the study and look at the teeth that they included in it, they were including teeth that were already pulpally involved. We know that if you have just a white spot lesion, they did a study with endodontists. They took out premolars with white spot lesions and looked at them histologically, and they saw changes in the odontoblast layer and inflammation. So if you're already applying this, they need to look at that on just a sound tooth structure and not lesions that are already inflamed. If we look at sites, this is really, really important. So you're probably more likely to arrest a smooth surface versus interproximal or occlusal surface. And that's why it's really, really important to go ahead and, if you can, on these occlusal lesions, to put a glass ionomer over that just to prevent the food impaction. And if you have enough room on these interproximal ones, try to get something in there so it can stop the food if it's broken down on the marginal ridge. And you're more likely to do an anterior versus posterior tooth. And that's just what we know is about what kids are eating in the surfaces. So anterior teeth, we have both smooth and interproximal, but we don't have those grooves. And these kids are eating this sticky stuff all day. So highly, highly consider, if you're going to do this, consider putting some in afterwards if you can. If you can't, then have the patient back for a recall. I will say application of Revastar, it can stain if you don't get that second step on for 90 seconds. And I told you I'd show you what I did in my office. I took a tooth that was extracted and I went and did the first and second step. And this is right when it came out. And this is what I got the next day. And I was like, oh, it's supposed to not stain, right? So I went back and I applied the Revastar for longer. And this is just a time-lapse video. I think we shot every few minutes overnight of the properly applying. Let me see if I can just start. I'm on the wrong screen, properly applying it. And you can see that it does darken a little bit, the Revastar does, but it doesn't turn that jet black that you see with the Advantage RS, but you have to apply it for 90 seconds. So you can have positive outcomes with it. And I think the Revastar Aqua makes a lot more sense now than the Revastar, the original one. And that's what I'm using at my office right now, but it's got the ability to use it with the second step without, and then also the ability to enhance staining, reduce the staining if you want to. So here again, just the 2 teeth afterwards. It's going to darken the tooth. It's a little bit darker. I will say that, but I think most of us have probably had that situation where that parent comes into the office and they were at another dentist and they said they're applying the silver fluoride product and they're really unhappy with the aesthetics of it. And I don't use a lot of silver fluoride or silver diamine fluoride on the anterior teeth just because I see this happening. I'm more likely to put them on a 313 call and try to get them to change habits at home than to have a patient come in like this and they're not happy. And then all of a sudden, if they don't have posterior needs, what do? We just had one where we did Hall crowns on to try to cover it up, but it's not really the most ideal to be doing that many Hall crowns with glass ionomer on a young wiggly kid. It's difficult. You may want to consider a traumatic restorative technique, or ITR. This would be selective caries removal. I really like, during the pandemic, I took these burrs and had them soldered into mirror handles with my orthodontic lab. And I really like these. I learned this from the Smart Restorative book that was published a few years ago. And it's I think it's a nicer way than trying to use a spoon to get the decay out. And I just found like I get a lot cleaner margin with it. And it's pretty acceptable to the kids. They don't have too much of an issue looking at that. And then covering that up after you scoop out some decays with the glass ionomer or a resin modified glass ionomer. So glass ionomers, I love them. They're great for pedo. They chemically bond to the tooth. They release fluoride. They're biocompatible. I use it a lot in my indirect pulp therapy because their coefficient of thermal expansions is the closest to dentin. So when the tooth changes temperature, it's going to expand and shrink at the same rate. And we know that shrinkage can cause some problems with sensitivity with composites. It requires moisture set, which is awesome. I'm actually doing all GI sealants now. I've switched, and our 5-year success rate is 89% of the teeth that I've sealed are caries and restoration free. Here you can see how it seals compared to a flowable composite with a dye leakage study. You can see this is why we don't get recurrent decay with these types of products as often as we do with composite, because they bond to the tooth chemically and they don't shrink back and away. You can also consider an RMGI. This is great for those high-risk kids at your office where you want a more aesthetic outcome. They are a lot more aesthetic than the glass ionomer, and they have some of the similar properties, but they do have their disadvantages as well. In class 2s, they tend to break out, but we don't get current decay. They'll wear a lot faster, and they need bulk for strength. So that can be an issue. Finishing, they aren't as aesthetic as a composite would be. And studies have shown that they have a similar longevity to composite, but I've had some times where these aren't strong enough to withstand the area that they are placed in, and sometimes that's a compromise you make if the parents want something more aesthetic. Again, these have very good properties against the micro leakage, and that's why they don't get recurrent decay. So if we have that teen that's in my office has all this work to do, this is what I'm putting in until we can get them under control with their diet and habits at home with brushing and flossing. We can also look at stripping. This was a kid in residency that just had tiny little spots interproximal on the radiograph, and we went ahead and just stripped those and not trying to restore those. These are really hard to go ahead and restore with the size of the tooth and the pulp. And so a lot of times I'll just end up, if I'm in the OR and they have decayed on there, I'll end up stripping. I've only seen one abscess on a lower incisor ever in my career. It's not saying it can't happen, but that's one of the options that I do. Or obviously, these younger kids are going to be getting those teeth sooner. Extraction is an option as well. I've gotten into doing a lot of these resin modified glass ionomer and glass ionomer strip crowns. And I will say that you can do this with the resin veneered SSC. They got to have really open contacts. If you got a bunch of them, the facing may fracture off. And these strip crowns are just a little bit more aesthetic with a material such as a glass ionomer or resin modified glass ionomer than the resin veneered SSC, because you don't have the silver. And I typically won't do all 4 in one visit. I will probably do 2 at a time, just because kids are, if they're wiggly, they tend not to turn out as aesthetic, and then you have unhappy parents and they're wondering why what you did when you're not really doing anything to do, but just covering it up, and it can be taken off. I would recommend you use a fast setting GI. I use Riva Self Cure HV or a light cured product that you can make sure that your crown has an adequate amount of bulk so it's not going to fracture. You would probably want to consider trimming the crown form. And then I always place a line, I'll show you in a picture here, on a mesial or distal line angle for a release so I can get it off easily. Some people also leave these on and take them off at another visit. Nothing wrong with that. That's going to protect it from moisture and setting up. This is just a kid that recently came in that we're treating with some Hall crowns. This one I'm actually doing 3D printed zirconia composite crowns to cover these teeth up with our 3D printer. So that's something I've gotten into, trying to play with the cements and see what's going to work best to keep those on for these high-risk kids since they have so much space. I use Space Maintainer lab crown forms. I know there are other companies that make them without the jacket. It's really nice to not have to trim off that jacket on the 3M crown. So consider using one of the companies that has these products that you don't have to trim it that much. And this is what I was saying when I placed that spot on the mesial or distal lingual line angle to have an easy release, because in the wiggly kid, I just want to be able to flick that off. And I don't see, with the high viscosity of the material that I'm using, I don't see a lot of material flow out of that. So there's not really any finishing you have to do to the crown after that's complete. I think, let me turn the audio off on this, I think. Over here. Okay, so here's a lateral incisor that we're just going to do a Hall crown on. So we're trying to size the crown first, and typically I'll have to trim these. They're usually a little bit long, but we want to find one that has enough bulk. So the first one didn't quite go down all the way. We can go ahead and size one up here while the kid's sitting knee to knee. And then after I get that sized up and I'm going to find the one that fits, I'm going to go ahead and have the kid just sit up in the lap of the parent while I trim off the excess for the crown and get it ready with that line angle to actually go ahead and cement the crown, just so the kid's not leaning back and in the way and I have a sharp object over their face or anything like that. So then we can go ahead, put that release in, and then titrate up your product. I think in this case, I can't recall, but I think I used Riva Self Cure HV for this demo. Yep, so you can see how thick this product is. I'll also use this to cement my zirconia anterior crowns as well. So here, this will come in, you'll be able to go ahead and place that crown, and it's pretty thick, so you'll be able to push any, blood out of the way if you got that when you tried it on. And then it's a really easy cleanup. So it's so thick, you can just go ahead and start cleaning up this after just a few seconds of letting it kind of sit together. So I'll come in with the not so sharp scaler or perio probe and get this knocked off. And then after that, once I get it kind of down a little bit more, I'll bring a toothbrush in to finish off the remainder of that. And here you can see not much came out that little slit that I cut. And it's really nice to easy clean up with the high viscosity that this product is. And I'll find that these typically will get me anywhere from 9 months to I'm just using the curing light to heat this up. This one does not like cure. Anywhere from probably 9 months to 2 years to get the kid by. And, at that point, we may have to replace it again, but we're avoiding sedation at that time in my office. And a lot of parents are conscious of that now, and we do sedation too, but it's nice to have this just as an option for some of those parents that want to avoid that and avoid the cost, and see how easy that is just to pop off with, if you have a kid making noise in your lap, it's going to be so much easier to do that than try to drill it off like we would normally. Here is a resin veneered one. So I will cement these with actually Riva Self Cure HV as well. So size of the crown. And then this is so thick. When you look at a glass ionomer cement or restorative material, the main difference is the powder to liquid ratio that will change the viscosity of the product. So if you have a thicker product like this, you have less liquid, right? It's like you're baking. So these ones don't look as aesthetic, but this is just another option for your patients These ones aren't going to fracture as much as the ones with the glass ionomer, but you're also compromising aesthetics, and you may have a stainless steel crown if that facing chips off here. But we've done quite a few of those at my office. Usually we'll start off with either the 3D printed one or a glass ionomer one, and then if they keep breaking, we'll go to that one. This is just an example of one that we did that didn't work out. So you can see we don't have any pathosis or anything. We just have, to go ahead and redo this crown or use a different technique for restoring this kid. Maybe they had disease progress and they need to go in and, have posterior teeth work on, and we're going to go to the hospital. Maybe that's the case. And then here's just another glass ionomer crown. This is a 2-year recall. You can see this high-risk kid, but we just chose to restore the one that was getting close to the pulp. Here you can see a nice outcome lasting over 2 years. Here's another 1-year recall into G. Nice ability for a deeper lesion to be arrested by just covering it up here. This one, hindsight, I probably could have gotten away with using the hand drills and placing it on a facial surface, but I didn't have those at this time. Here's another kid we did one on, and we're going to reevaluate. And here they are at a year, and the other one got larger. So we ended up progressing and doing that one. But they can have some good longevity. Here's one, another one, deeper lesions on D and G. Here she is coming back at her recall. And then I think this is a few years later, she came in again and she's having troubles with that one, but the parents didn't want sedation. They didn't want extraction. So this is what we did, and it's worked out well. We haven't had any issues with that tooth. And I think she's 3 or 4 years into this now. So here you can see a resin veneered one. Let me see if I can get it to there. You can see these aren't as aesthetic. They're very bulky. So I'd make sure if you're warn the parent that this is it. I have this picture and I show them this before we do it. And I say, this is what it's going to look like. And it can be very prominent central incisors. And yeah, so they see it. And then that's part of our discussion of consent. Here's another one with some deeper lesions. We end up doing just glass ionomer. Here's one that just came in actually recently. So this was a family that moved to the United States from another country, and they did not by any means want to sedate either of their 2 kids. So we ended up doing these resin veneered Hall crown. She had plenty of space. Here she is 4 years later. She just came in actually yesterday, and these teeth are now exfoliating naturally without any surgical intervention at all. Composite, I don't do a lot of composite restorations on my anterior teeth. I think canines are probably the most common thing I do. It is more conservative. They're beautiful when done right. The problem is you have to have adequate isolation. You got to have multiple steps. And the bond strength in primary dentition is not as good as it is with the permanent teeth because of the way that the teeth develop. And they're more likely to get recurrent decay than a glass ionomer is. We have different types. We have a flowable, and then we have a packable. I know some people use the flowable to do their strip crowns. They just have a little different in the filler. So you're going to have a higher filler content and higher viscosity with a packable resin. It's going to wear better than a flowable, but we're talking about the primary dentition here, so you may accept some wear as well. This is the composite I'm using right now. Luna, it's a nano hybrid. It's got kind of that chameleon effect that the Omnichroma has. It is very, very nice to work with. It doesn't stick to your instrument, and that's what I really like about it. And then that chameleon effect, they've got a variety of shades that can be used, and I've just really enjoyed working with this material and how it finishes and at this time. That doesn't mean something else won't come along, and I'll change as materials keep to adapt and come out. Composite contraindications. This is from Kevin Donnelly. So inadequate isolation. We know that composite cannot have the moisture tolerance that a glass ionomer does. High risk patients. I talked about that earlier. You have that high risk kid that has, the teeth have only been in the mouth for 2-3 years, and they've got every tooth that needs treatment. That's probably not your best choice to use a composite isolation, and poor oral hygiene kind of feeds into that as well. That goes hand in hand with our cares risk assessment, determining who's high and who's low risk. This is an emerging field. I know there's a lot of kind of bad press about Activa a little bit in some of the forums online with pediatric dentists, and that's because when they first came out with the product, they said you can treat it like a glass ionomer and you don't need to etch and bond. And what they ended up finding out was, yeah, you do need to etch and bond where you don't have retention. So a lot of people are getting failures and getting upset. These newer materials are bioactive. They release calcium and fluoride. They have a light and dual chemical cure. We don't have as much data on these as we do all the other dental materials, but this is something to keep an eye out on for as we continue to develop and advance in dentistry and try to find something that's going to be able to withstand the high risk patients in the oral cavity and the challenges that the oral cavity has with restoring a tooth in it. Another product I tried, Surefill One. This is essentially a self-adhesive composite resin. So essentially it is, from what I understand, it is a flowable mixed with a bonding agent. And I use this when they had the first deal coming out. And one of the problems is with it, the IFU says you got to wait 5 minutes before contouring and finishing. And if you're treating kids, we know you don't have 5 minutes to wait. That could be the difference in losing the kid and finishing. So I think it has some indications. I haven't had really any issues on my recalls with it, but that 5 minutes can be a problem for me. So if we looked at the class 3 restoration, this is why I don't do a ton of class 3s, is because the enamel primary teeth, they have more organic matter. So they mineralize over 1 year, right? When the mom's pregnant, the baby's already mineralizing those teeth. And permanent incisors go 7 to 8 years. And that's a big difference in the mineral content. They have a prismaless layer, and it doesn't respond as well to etching as a permanent tooth. So I highly suggest, if you're going to do this, I like to do a modified class technique, and I'll show you some of those prep styles that are taught in our textbook. Another challenging thing about these class 3 restorations is if you're doing a lower incisor, you may have an area you can't prep big enough without getting into the pulp to have retention for that. And we know that if we have to prep more and get into these larger pulps on the primary teeth than permanent teeth, we could have a pulp exposure, and then all of a sudden we're looking at pulpal therapy as well. The etch is not always going to be sufficient enough, just because we don't have as much mineral in the tooth to have those resin tags go into. So not to say these can't be done, I just don't do them a ton. These are some of the modified preps that I like to do, is the dovetail and then the modified slot prep. So in this case over here, if you're like doing this and you have a distal lesion, I'll come down and bring that in around the cervical just to give that a little more retention for the restoration. Here's just an example of a young kid I treated in my office, and we did this in office and went ahead and did that modified prep where we brought it down around, and he had a good result, and these were able to go until they fell out. Nowadays, I might be, if they don't have a lot of other needs and it's this situation, I might be more likely to strip that and get that open than do this. This was done when I first started practicing, and I thought I needed to treat every lesion that came in and that I saw. Canines, I do a lot of the dovetails on the canines as well. Maxillary canines, if I'm in the OR, I always kick myself for doing a class 2 instead of crowning the tooth, because these teeth need to last for a little bit longer. But that's one of the things you learn as you practice, and that's why they call it the practice of dentistry. Class 5 restorations, mainly for these, I'll use a GI or RMGI. And for that, you wouldn't want to do the bevel on these preps because the glass ionomer needs bulk for strength, and it'll fracture at that point and then be a potential spot for plaque and food infection. But just an example of a class 5 prep. If we move into full coverage now, the indications for it are kids with extensive decay. We know that high-risk kids that are young are probably better off with full coverage, even on some simple things, than because of their habits. Trauma, you may have a tooth that gets fractured and you want to do pulp therapy and cover that up afterwards. We know teeth with multiple surface lesions, it's going to be better to do a crown than a 3-surface amalgam or composite. If they have decalcification, there is indication if they have decalcification and a lesion on the other side of the tooth to go ahead and take care of that with full coverage as well. Hypoplastic teeth, we're seeing this quite a bit on second primary molars, and those can get cavities pretty quickly, and it might be something you want to go ahead and, instead of trying to do a glass ionomer or filling, go ahead and try to place a crown over the tooth. We know the APD guidelines say following pulpal therapy, unless the tooth is going to exfoliate within 2 years, or it's just an occlusal lesion. High-risk patients, we talked about that just a few seconds ago. When I go to the OR and we use GA, if they have a cavity on their posterior tooth, they're pretty much getting a crown unless there's some other issues such as ectopic eruption. And I've had very few cases that have had to relapse and go back to the OR. And we just explain to the parent why we're doing that. And most of them are accepting. We offer zirconia crowns as well. So that's another option for them. And then the Hall technique, we talked about that a little bit before, but on posterior teeth and anterior teeth, that can be an option. Stainless steel crowns have been around, I think, since the 40s, when they were introduced into pediatric dentistry. They're very easy to place. You can do minimal preparation and do indirect pulp therapy, or you can do no preparation with the Hall crown. They're very, very successful. The problem is that people have with them is they're silver, and not a lot of people want to have that silver in their kid's mouth. They do have a higher area of gingival inflammation than some of the other products like a zirconia crown. You can wear through these over time. They can come off. I know Halloween just went by a few months ago, and I'm sure some of you had some kids coming into your office with crowns that had debonded. They're made of nickel chrome steel. If we look at anterior crowns, I believe, I'm not 100% sure on this, but Hugh I know doesn't make anterior stainless steel crowns, but I know New Smile does make them, and 3M also makes them. Difference in the material, the 316L is a little bit less or more resistant to corrosion and a little bit stronger metal than the 304 stainless steel that some of the other competitors are made out of. There's pre-trimmed and pre-contoured. I know the stainless steel ones that I have that are from 3M are Unitech, and they are just pre-trimmed and not pre-contoured. And you can, if you have a kid come in with the facing come off on an RV, SSC, or a stainless steel crown, you can go ahead and prepare a facial and place a composite. That was kind of an older technique that was used back when there were only stainless steel crowns. I typically only utilize these for canines, and it's usually a Hall crown situation that we're going to do it on a kid that's going to need that tooth for a little bit longer. But I have a kid on hand. If I get into a situation, I have it to use and I can use it. Resin veneered stainless steel crowns. These were pretty popular before the zirconia crowns came out. They're pretty easy to place. You can, like I said, you can do minimal preparation with these or no preparation, like we had talked about with the Hall crown earlier. They have high success rate. They're a little more aesthetic than stainless steel crown. You still have the problem because they are stainless steel underneath with gingival inflammation. We don't advise that you crimp these crowns because they can get a fracture when you do that. And the most common reason for failure is debonding of the crown and the crown facing. So we've all had those kids that come in with these and they're chipped off, and the parents, that's like an emergency visit, right? The kid fractures the white facing off and they think the kid, there's a cavity underneath the tooth. I can't tell you how many times in my career that's come in. I'm like, no, they just fractured this. Here are your options for replacing it. It's nothing's wrong with the crown. It's just it's fractured off there. And it's not as aesthetic, but it'll still do its job. And then these, you can't reheat process them with a sterilizer, so they have to be cold sterile. That's another disadvantage when we look at infection control. So I use the same preparation technique that I do for my zirconia crown. So I'm just going to cover these later, but here's just an example of 2 teeth that were treated. This patient's insurance didn't cover zirconia, and we went with this instead of composite at that time. We're going to talk about next, strip crowns, our full coverage composite crowns. They're very aesthetic. They have a different preparation technique, which we'll go over here, than doing a zirconia crown or one of those resin veneered ones that I do. And the disadvantage is they take a lot more steps. So you have that young kid in your chair and you're all of a sudden now having to etch, to bond, to place the crown, to cure, have them sit for the light cure, get the crown form off, and then finish it. That's a lot more steps than just prepping and cementing a zirconia crown. And you have to have good isolation for it too. So if the kid's wiggly, it may not work as well. You do have composites that have shrinkage and then leakage. I mean, we're taking this bulk of product that we know we normally would cure in 2 millimeters, and we may have some areas that are higher than that. So unless you're using a material where the depth of cure is really good, that may be a concern as well as far as leakage and shrinkage. They are prone to fracture more than a zirconia crown. I've done these at my office. We still do them. They are a tool that we use. but here's just a case that we did that I'll walk through. So for these strip crowns here, I'll start with my occlusal reduction and then proximal reduction. And my proximal reduction, I'll try to stay above the supragingival. Sorry, I'm going to say subgingival, but supragingival to avoid getting any hemostasis. I'll go ahead and then do caries removal. I find out that if I have undercuts, that will help with retention of the composite. And here you can see this is after my final preparation for these 4 anterior teeth. We have a very good area where we have don't have issues with hemostasis. That changes a little bit here when we try the crowns in and figure out the size that's going to fit the kid. You can also size the crowns beforehand, but you won't be able to see how they're going to seat until you attempt to seat them. Go ahead and do hemostasis. So here, aluminum chloride is what I was using here in this case to obtain hemostasis, and then go ahead and etch the teeth, and then we'll go ahead and place our bonding agent on those and cure it. And then I'll go ahead, this is a case where we did Activa. So I went ahead and placed the 2 crowns on. I had my assistant light cure for 5 seconds, and then we went ahead and removed the excess because it won't fully cure, and then went ahead and fully cured these afterwards. Usually I'll do ENF and then come back to D and G, and then go ahead and remove the crown form after that, and go ahead and complete your finishing and contouring of the crowns. And it is another tool that we do this sometimes when the kids don't have coverage for a zirconia crown and the parents don't want to do the resin veneered crown. We'll go ahead and do this. Preformed zirconia crowns that came about here in the last few decades, and they're really nice. They look beautiful. They have great strength. The gingival health is better than the stainless steel crown. I think the most recent study that was in the APD on them is saying that they're actually better than stainless steel crowns as far as longevity. So something to consider at your office, adding this if you don't already do it. They do take more time to prepare. There's greater reduction than the stainless steel crown. Obviously, zirconia needs to have a certain thickness for strength, and stainless steel doesn't need as much. It does have a subgingival preparation, and we know that our cementation process, we want to avoid bleeding and heme, and that can be another challenge that's added to these crowns. It does take time, but the more you do, I can do D, E, F, and G in 3 minutes just preparing. I mean, it takes longer to cement and get that done, but it can be done pretty quickly. You can't crimp these, and then they're really difficult to adjust. So these are some of the major manufacturers out. They all have different kind of things. I think you can find one that's going to work in your hands. I use personally the sprig crowns because they have the retention grooves. Kinder crown has retention grooves as well. And then Chang crowns has a knife edge that will kind of curve in to try to retain the crown. And then the Acero crowns have these little dimples you can see in the intaglio surface of the crown. If you're looking to save on cost, Acero and Kinder crowns, they both have a universal crown, so you don't need to stock right and left of the anterior. So if you don't do a ton of these, that can save you a little bit money. Obviously, you're going to trade off for aesthetics there, but you don't have to have as much inventory. All of these, you're going to need the space loss crowns. They all have them. It's very beneficial if you're doing back-to-back crowns in the posterior to have space loss crowns, and it's very beneficial if you're working on canines in the anterior region to have a space loss crown, because you may be doing 2 stainless steel crowns and then all of a sudden you don't have room for the one that you tried on because you cemented those, and now your zirconia crown doesn't have enough clearance to go through the interproximal. So the space loss can give you a little play there. New Smiles is a trying crown. That's because of the cementation and contamination of the surfaces. With the Kinder crowns and the sprig crowns, you're not going to need that because you have mechanical retention as well. Kinder crowns does have multiple lengths, a short and a long. I think most people use the short version of their crown. One of the issues with these is also if you're doing like these big cases like this one that I did, you're going to have a hard time adjusting any occlusion if you get it high. I know it's probably not going to be a problem because of what we know about the hall crown and teeth being intruded, but that can be something that can cause a little discomfort for the kid afterwards. Biocompatibility, here you can see resin veneered crowns that I did on the left, and then zirconia crowns of both of these kids on D, E, F, and G on the right. And I think we can all appreciate which one has healthier gingival tissue, even though probably both these kids probably have the same oral hygiene, would be my guess. I mean, they've got pretty similar pattern of decay and posterior decay going on in their oral cavity. here is, let's see, we'll get a video started. So this is just a preparation technique that we'll walk through. It's going to take a little bit, and then we'll have some more pictures and we can move into a Q&A session here. So to size these crowns, I'll start sizing them before I even pick up a handpiece. So I'll hold up the crown that I think is going to work up to the tooth. And here you can see the assistant's taking a little time to probably find the crown that I asked for, but we'll hold that up and we'll size all the crowns. Usually your centrals are the same size, and then the laterals are one size different, typically, not always, but most of the time that's what I'm finding. If I've got a 2 central, the laterals usually 3, one size bigger, but obviously not every patient read the textbook, so that can be different. So this kid, we're going to go up a little bit to a size 3. That's the crown I like, so we'll do that for E and F, and then size up D and G, and then we'll go ahead and get started here with preparing these teeth. Sorry, I didn't have time to edit this video, so it'll pick up here once we get to starting to prepare the teeth. Let me see if I can skip over a little bit here. So a little local anesthetic. Okay, so we'll start off with the occlusal reduction is what I do. So I'll typically do all the teeth that I'm preparing with the occlusal reduction at that one time. And after we get that reduction done, there is a chamfer burr that you'll want to find, and you can use any chamfer burr that you'd like. This one I'm using is 0.8 millimeters. It's the easy prep burr. And you want to go ahead and make a super gingival racetrack or circle all the way around the tooth here. So we're going to go ahead and do that. And that's what it's going to do. It's going to move our margin that we're going to place in. So when we go ahead and do our subgingival prep, we can go ahead and get in and minimize the amount of bleeding that we're going to cause when we stick that burr below the gums, because now we have a ledge that has moved the margin away from the gingiva. So we'll go ahead and do this 360 degrees around the teeth. Typically when I do these, unless I'm doing IV sedation at my office with an open airway, I will cut with water. It's my hunch that on these posterior teeth, and why we're seeing that ghost resorption is because of the heat that's generated in the additional preparation that we have to do with these teeth. I know some people say it's the hardness of the zirconia, but I don't see that kind of resorption on the anterior teeth that I've seen on some of the posterior teeth that I've seen people post. So that's my guess. So unless they're an open airway and we're trying to avoid water on going down the airway, then I'll go ahead and use water if we have a throat pack and protected airway for the kid in the under sedation. Obviously at the office, when they're awake, we do use water as well. So after this step's complete, we'll switch our burr out and we will find one. This is just doing the incisal reduction like you would if you're prepping an adult crown, to move that in the facial bevel. And then we'll switch out to a pointed flame burr and go ahead and remove that. It's usually entering at a line angle and going around the tooth. And you can do what they call ring around the rosy and keep going around the tooth once you get it to the point where you're removing that ledge. So do that pretty quick. And then once we get to trying on the crowns, if they're not fitting, you can usually troubleshoot where it's at and either ring around the rosy again, or find out if you're having an area where you're binding up on the surface on the mesial or buccal or lingual or distal tooth. So we'll go ahead and do this to all of these crowns, and same process. When you look at these cases, like this one's a pretty easy case because we've got a lot of space. We don't have a lot of crowding. But when you get into these other cases where you got a lot of crowding, that's where your difficulty is going to increase with these. So if you're looking at getting started into these, or you haven't done a ton of them, I would suggest case selection. Use cases where you have space between the teeth, so you're going to have room for your crowns if you have a little bit more bulk area to go through. I've done some cases and it's just been really, really difficult when they have crowding to size these and fit these and get them in the right spot where it doesn't look like they have crooked teeth when they came in straight teeth or straighter teeth than they had. So I'll go ahead and round off the incisal edges here so we can remove any spots that might potentially be sharp. And then we also need to come in and remove the cingulum. So that can be done just with the football diamond burr if you have one, to remove that cingulum. Here you can see just so that bulk is not there and the crown's going to be able to fit. The easy crowns have a little more flair to them in the buccal lingual direction. So that's one thing that's nice about those is they are a little bit thicker, but they do have a little bit more of a flair for you to be able to seat that down and not have to reduce as much tooth structure, which can be beneficial in some of these cases that we see. So we go ahead and reduce. And then if you have any areas here, we're just smoothing down the facial again and the edges there, because we don't want zirconia, we know it can fracture if it's got some sharp. So if you think of like a pencil, would you rather be poked with the sharpened end or the eraser with the same force? Probably the end with the eraser. So I'm going to go ahead and try these crowns on here. I'll usually try E and F on, get them where I want them, and then try D and G on. I'm going to have to go back here. It looks like a little bit on D. This one's not going to go all the way. Looks like it's binding there. So we're going to go around that tooth a little bit more. And then we'll go back and do all our adjustments to get them where we want. And I'll go ahead and I think E and F are fine here. So we're going to go ahead and get that tooth D to go ahead and go back and ring around the rosy again here and reduce where we need to get that crown down. So it looks like I thought it was binding here a little bit on the cingulum, and I think probably on the distal facial, if I recall right. So you can go back and adjust and then try the crowns in again and make sure they're getting all the way down with your aesthetics. Then one of the things also I've noticed that we'll talk about a little bit later here is taking pictures is important to improve. I have improved drastically by taking before and after pictures on these cases. And it might not be something that a parent can notice, but as a dentist, you can definitely notice the people that are taking before and after pictures on some of the cases that they are posting on social media and things. And I just want to keep improving at my practice and improve aesthetically for my patients. So I'll show you some cases where I'm not perfect, and that's okay. But I'm just working to get better on my own and just trying to do the best thing I can for my patients. So here's the ring around the rosy again that we're going to go, just because the crown's not seating all the way down. And that's usually one of the first things I'll go back and do if I'm having trouble shooting the crown and I can't figure out where it's getting bound up at. And then I actually cement these with the glass ionomer restorative. The Riva Self-Cure HV is what I use. Let me skip and see if we can move up to, let's see, where was I? So we're trying them on here. Let me get back to, I can post this video online too. So using the aluminum chloride again, don't use ferric sulfate, the brown stuff, it can stain. Go ahead and dry the tooth off the best you can. And like I said, you can use a glass ionomer or a resin modified glass ionomer cement with these, but I tend to find that the glass ionomer is a little bit nicer if you got something a little bit moist and a little bit bloody. And we'll have more micro leakage with that, but we're gonna have less debonding from what we've seen with stainless steel crown. That still is out with zirconia. But you can see that Riva Self-Cure HV just kind of pushes that out, all the blood out. It's so thick. It's kind of like that thick mix of Key-Tech that people talk about with these crowns. And I'll get E and F set and start cleaning up. Do, like I said, with my strip crowns, I'll do the two headlights first and then come back and go ahead and jump into the laterals, because people are going to notice E and F more than they are the lateral crowns. Here you can see I didn't quite, if you're looking at perfection and trying to get things, I didn't quite get F in the right place, but don't pull the crown back off, or you can have cement leak into it. If you're going to redo this, just take it off and go ahead and start over with hemostasis and everything and fix it if you're going to do it. Don't pull it off and push it back on. You can rotate these, but you don't want to get any of that blood, the gingiva is still bleeding, into the crown. So here, coming back again, doing the lateral incisors at this time. And we'll see if we can get to the end here. So just cement cleanup, and then I usually end up cleaning up with a toothbrush. And the only complaint there is F and having that incisal edge be a little bit off, but everything else looks pretty good for this patient. For glass ionomer cements, like I said, they're just the same as the restorative material. They're an acid, that's the liquid, and a powder that is the silicate. They need water for the acid. We know there's an acid-base reaction, and that sets as part of the cement. So it's really important for some of these newer products as well out to have a little bit of moisture and not be completely without it. Like I said earlier, your difference between a cement and the restorative material is just changing the bases on the powder and liquid ratio. More powder, like if you're baking with flour and you're adding the more flour in, it gets thicker, right? So that's what's going to change the viscosity or how thick the material is. It's also going to change the material properties too. They all have bioactivity, exchange ions, calcium and phosphate with saliva, and then we know they do interact with fluoride as well. So these are kind of our glass ionomer cements. We have the eluting cements, GIs and arm GIs that we would think of as like a Fuji Sem or a Keytech kind of cement. And then we have restorative that you might think of, of Fuji 9 or Fuji 2LC or Ionolux, Ionostar Plus, or some of the Keytech products or STI's products out there. So you can get delivery of cements in different ways. You can do a thick mix of arm or a glass ionomer. You can get it in capsules and titrate it. And you can also get auto mix syringes. I'm using Fuji Sem Evolve right now for my arm GI, and then for the anterior teeth for cementing these crowns, I'm just using the Riva Self Cure HV. If we look at stainless steel crowns and the types of cement, so we know that GIs have more micro leakage, but we don't see a difference in debond rate. So I would just advise to you that you think about the environment. If you've got an uncooperative kid and moisture control issues, or a ton of heme, you might want to consider a glass ionomer cement over a resin modified glass ionomer cement. I mean, I've had to do that many times where I have a kid that the spacer, they keep pushing off with their tongue, and I'll just go ahead and take the Riva Self Cure HV. It's so thick, and use that as my cement. What about zirconia? Well, we have the same in vitro studies showing more micro leakage with GI, but we need to have more studies to determine if an arm GI or GI is better. So just keep in mind, I usually base it on the cooperation of the situation for the kid. Here's another video. This is just cementing a canine here. We're getting closer to the Q&A here, so we're almost done. But I'll go ahead and fill that up, and then pretty easy to cement it on and have that push everything out. I know it's a little more expensive than hand mixing on your own, but I can't remember. I've had a time where one of these anterior teeth have come off. For my posterior teeth, you're not going to get enough product in that to use. You have to use multiple capsules. So for those, I do go ahead and use the Fuji Sem Evolve. So like I said, take photos. Here you can see not an ideal outcome for me. And here's one I took a post-op and I said, whoa, I took the picture and everything looks good except we got cement in the middle. So I was able to go back and clean that cement up for the kids. So I don't have to do that post-operatively. You can see here more difficult cases as we lose and have more crowding, and it's going to be more difficult, but we can still get, by taking before and afters, improving our aesthetics. This is a very difficult case, lots of crowding here to get all these down. This is the best I could do. I think it's a nice outcome considering where the kid started off with. But as you take more pictures, you can, this is a very good case for me. I'm very happy with the way this one looks. You can get better by doing self-evaluation. This is, I think, no, that's not the one I showed you, but another one where F's a little bit up. We talked about a lot of different things today that we do. We talked about hall crowns. We talked about resin veneered crowns. We talked about strip crowns. We talked about full coverage. We talked about restorations. There's lots of ways to do this. And, you know, there's not one way to treat every patient, but there are different ways that you can look at as far as behavior management and treatment planning for these kids. I am going to move into some Q&A since we have about 5 minutes left. So for your CE credit, I'll put this back up on the screen here after I go through a few more slides, but it's CE for decay. 3, I believe, is what we're going to use for this one. So if you missed my last webinar on the patient experience with Kayvon Mott, you can go ahead, and that's on demand now at pediatricdentalce.com. You just take a quiz and the survey on that one after you're done with the video. And if you're looking at coming, if you want to come to one of my hands-on courses, we have some coming up here. We're going to be in Denver in July. We've just booked that one at the Embassy Suites downtown. We have another live free course coming up next month with Kevin Ohlendorf, and he's going to talk about space maintainers and issues with the labs and 3D workflows and some of the things that they're seeing with stuff that people send in, and some how to avoid problems with your lab with space maintainers. They are a great lab. That's what I use. Great products. I have spacers fit about 95% of the time by just taking an impression. I know a lot of you might be at the APD. I'm actually going to be there, but I'm going to be doing a course for pediatric dental seminars at the time. I know it's over the same date, so it could be a conflict. And then if you want me to next month, if you want me to ship you some typodonts, so the actual kids that I've treated at my office, these are 3D printed. It's actually what you're going to be doing in the kid's mouth. I'll ship these to you. I'll ship the burrs to you. I'll ship the crowns to you. We'll just ask that you ship the crowns back in a self-addressed or labeled to me. But we do have that course coming up, and we'll talk a little bit more. I didn't talk too much about zirconia and the material properties, but we'll get in a little bit more to that. And then we're going to spend a lot more time on prepping teeth and doing the typodont. We'll have anterior teeth, D, E, F, and G. We'll have an easy case, some more difficult case. We'll also have a canine, and then we'll do back-to-back posterior teeth on a mandibular molar is what I'm planning on. So you get a few typodonts, you get to practice a little bit in the comfort of your home. You don't have to travel. So keep that in mind. If that's something you want to do, you're definitely welcome to sign up. And we will have a cutoff date before that course, just because I have to ship things out to you. So let me move into some questions. It looks like we have a few questions. How do you get hemostasis with the zirconia crowns if the gingiva starts bleeding? So pressure and time is really good. That's a really great question. A lot of times, though, I'm not using the aluminum chloride anymore. I'm going to have prepping my teeth and then holding a gauze on there with good pressure. And I'm finding that when I go to get my Reva Self-Cure HV, that thing is so quick and it's so thick, it just pushes everything out, and I don't have to really worry as much about heme. So most of the time, I'm just using pressure with a wet gauze on the gingiva. But we definitely have the HemeRx pellets. We have the Viscostat Clear, the aluminum chloride, and I have Hemodent. We have it all, but typically I'm not finding out that I have to use it all the time. So when you prep for anterior teeth, do you use zirconia, anterior gyrus isolation? I have that. I got that during the pandemic, and it's still sitting in the box. So yeah, that's an option you can use. I usually will put in the cheek retractors. Let me go back to that slide, see if I can get to that one. Yeah, here, you can see I'll prep with these cheek retractors in if I'm in the OR and have throat pack in, and maybe a molt if I need it, but that kind of opens up the kid too. So that's what I've found works for me. Obviously, if you got that anterior isolate and you can use it, great. And obviously this probably wouldn't work with an in-office sedation, but that's something that I found. I use an isolate in the OR though, definitely on the posterior teeth, but not typically as much on the anterior. I like to use these retractors that you can get. I get these on Net 32. They're autoclavable. And yeah, there they are. So something like that. And let's see. Yeah, that's it. So yeah, the area is opened up with those cheek retractors. It just holds them open when they're sleeping. So if there are any other questions, I'm happy to hang out here. I'm gonna put the CE slide up. I'll hang out if you want to drop one in there. Yeah, you got a short survey that you'll be able to take here to get your CE credit. If you got an AEGD number, be sure to place that in that question. I fixed the survey from the last time, so we won't have any issues, and then we'll get certificates mailed out here, emailed to you over the next week after people have time to take things. And then we'll have this course on demand as well as we continue to build our clinical library for everyone. And it's just been a pleasure to be able to take over this company from Josh Wren and be able to give some CE and give back to the community. And looking forward to everything that we can offer here with hands-on education too, as we take that to the next level with the 3D printed typodonts. So thanks again for joining me. I'm going to go ahead and stop my screen share. I'll leave this up for just a little bit if you need to do this. And then the survey will, when the webinar closes, I'll probably close it here in about 5 minutes, since we're right at 3 o'clock and we got our hour in. So how many teeth can you apply SDF on at one visit? Well, that is a great question. So APD guidelines are 1 drop per visit per child. So depending on the size of the lesion and the number of teeth and the cooperation of the kid, it can vary. 1 drop can usually be used to treat 3 to 4 teeth. If you got bigger lesions, you may be applying more of the solution and not being able to get that to every site that you'd want. So typically, if I'm going to apply SDF in my office or a silver fluoride, I will go ahead and apply one drop. If I can get all the teeth I want to apply it on, I will. I'll have them come back in 2 weeks. I'll do a second application because we know after we do a second application, the efficacy of SDF jumps up. And then at that visit, I'll do a smart technique if I can. If it's a smooth surface and I can't do that, I'm not going to be able to get any retention for the GI without picking up a burr. So those cases, I don't. Another product you might want to consider now, if you've got like white spot lesions or interproximal lesions on these kids, is to maybe consider picking up a product like Curodont. I know that has a lot of excitement. It's a peptide that can help rebuild enamel by pulling in the calcium and phosphate and fluoride. So if that's something we'll see, I think coming over more of these minimally invasive products come out. Really exciting times for us as pediatric dentists, because if we don't have to pick up the handpiece and we can focus on prevention, that is the best way to not have to work on a kid, especially, with, minimal needs and some of the experiences that they come in with and some of the experiences their parents have had. It's nice to be able to offer things like the Hall Crown to your kids. And I think the Hall Crown it's got a great use. I think we're finally getting some adaptation around it. I hope more people continue to embrace it and use it as an option for some of these kids, so we don't have to sedate as many kids or have negative experiences at the dentist. That's a great question, though. Where is the course survey and completion code? I think I forgot to put a QR code up. You will, let me see if I can get that up. Let's see. I think I was going to have it emailed out. I'll put it here in the chat. Let me get that pulled up here. So that's Facebook webinar. Let me get this out of the way. So we have a survey. And it will show the link on it. Follow up, and then I think I can click this. And let me get back to the chat here, because I know you probably can't see my screen. Type answer to question. So I think that should pull up the link. I'll email this out to you. I don't know if I put it in the question or the chat. Here's in the chat. Sorry about that. That should pull up a survey for you. I'll email it out to everyone as well afterwards. So I apologize for not having that QR code. What material do I use to 3D print zirconia crowns? So there's a lot of materials that are coming out now. And I think starting in 2024, if it's got more than 50% zirconia in it, you can bill it as a zirconia or porcelain crown. Right now, we're billing these out as composite crowns, mainly doing them in cases where we do a stainless steel crown on a permanent tooth, or instead doing an onlay or a crown for them. The material I'm using right now is from Onyx. It's actually Sprint Ray, sorry, it's Onyx. And then also there is a Sprint Ray version of the crown. So I think probably in our lifetime, we'll be 3D printing our own crowns, prefabricated white crowns at our office. I think there's some issues with bonding right now that I'm seeing, especially with some of these Hall crowns, trying to figure out what cement's going to work best for bonding to the composite hybrid, the zirconia composite hybrid, and then as well as a squirmy kid or a bloody situation. So I think we'll get there, and I think we'll be a point where you'll probably all have 3D printers at your office and be printing these crowns for primary teeth. That's another great question. Someone's going to figure it out. Okay, one more minute, and I'm going to go ahead and close this off. I do not see, let's see where we're at. So I put that in the chat. I will email it out for the CE credit. I don't think I have it up right now, but let me get back into 106, and then let's go back there. And then the CE will be sent to you. The link is in the chat. I will email that out to our list of attendees as well from info@pediatricdentalce.com when we're done, since I don't think I had that survey set up. Always something I'm screwing up here. So last time it was the email, and this time I forgot to check that box afterwards. So Well, thanks again for joining me. I will get you your CE. I will be sure to follow up. I have your emails from registration, and I'll send a link out after we are completed. So thank you all again, and have a wonderful weekend.